Good afternoon, everyone. Welcome to our MGFA webinar this afternoon on sleep and myasthenia gravis. My name is Dova Levin, and I am the National Senior Director for Education and Patient Programming. Today, we have Dr. Urvi Desai, who is board certified in neurology, working at Atrium Health Neurology Specialty Care in Charlotte, North Carolina. She holds subspecialty certifications in neuromuscular medicine, sleep medicine, electrodiagnostic medicine, and electromyography. She focuses on acquired and hereditary neuromuscular disorders and has a special interest in the overlap of sleep and neurological disorders. Dr. Desai is an MGFA partner in care. We'll be speaking to us today about sleep and myasthenia gravis. Just to say thank you to our sponsors for today who make these webinars possible, our national presenting sponsors, Alexion and Argenix, our national collaborators, Amgen, and our national sponsors, UCB and Johnson & Johnson. I'm going to stop sharing my screen, and Dr. Desai, you're welcome to share your screen, and you can begin the presentation. Oh, one thing, when you have questions for the audience, when you have questions, please put them in the Q&A box, and we will get to as many of them as we can at the end of the presentation.
Thank you, Dova, for the invitation and MGFA to talk about this very important topic in the lives of patients with myasthenia gravis. We know that sleep is so important, and we know that sleep specifically and in particular ways get affected in patients who do have myasthenia gravis. So again, I appreciate and thank you so much for invitation. All right. So the objective for our talk today is that, of course, we'll talk about what's the importance of having a sound sleep. What are the correlation of sleep disorders and myasthenia gravis? We'll also talk about some separate sleep disorders that occur in patients, in general population, but also in patients with myasthenia gravis. And then we'll talk about good sleep hygiene and tips to improve our sleep. So why do we sleep? We sleep almost 1/3 of our life, we sleep, or sometimes more than that. And why do we do that? We do that because we want to rest, repair, and rejuvenate. And that occurs in the multiple functions across the lifespan. And the one important thing is that there is a physical restoration, right? When we sleep, our body tissue repairs, it builds bone, muscles. Young children, their growth hormone gets released while they are asleep. And so it's very important to continue to grow and continue to repair our body tissues. It is also very important for the cognitive function because we know that sleep enhances the memory consolidation, learning, problem solving, etc. It is also very important for the emotional well-being. If we don't sleep, we feel very stressed, very anxious, very irritable. And if we have missed a previous night's sleep, you will see how you feel the next day. It is also very important for the immune support. People do tend to get more infections, etc. Or it also helps to fight infections if we sleep soundly, and it strengthens the immune system. It's very important for the heart health because the resting heart rate and the blood pressure do reduce during sleep, and that's very beneficial for the cardiovascular health. And in patients, especially who do have sleep apnea, we know that there's a strong correlation with the cardiovascular comorbidities. Weight regulation is also another factor because sleep affects the hunger, hormones, and metabolism, and it does have a very strong impact on weight management and cellular repair, detoxification, etc. So as you can see, sleep has multitude of functions. This is the slide not limited to patients with myasthenia, but this is predominantly in our US population. As you can see, that numbers are quite astonishing. Like 70 million people, Americans, suffer from sleep disorders, and 60% of them have this in a chronic form. So it's an ongoing issues with these patients. Around $63 billion is the cost which goes into lost work performance because of the sleep issues, mainly because of insomnia. We see that almost 30 to 35% of global population is affected with transient insomnia, but 10% of the people have a full syndrome of insomnia because it definitely affects the multitude of functions. 6,400, for example, estimated total fatal crashes that occurred because of the drowsy driving in the US each year because of poor sleep. So as you can imagine, that people do not sleep enough, people remain sleep deprived. And the graph here with the American map here, it shows that it's actually a very good a map to study. It's a county level short sleep duration, people who sleep less than 7 hours among the adults. And it's a different population strength. And here in the rural areas, as you can see, it is a little bit better. But then if you go in the urban areas, for example, and in the New York or even here, in the Southeast region, a lot of people do not sleep enough, almost half of the patient population. So it's very important that we ask questions to ourselves, how is my sleep? And we want to ask ourselves, do I have any difficulty falling asleep? We want to ask if I have any difficulty sleeping throughout the night. Do I wake up with dry mouth or sweats? Has anyone noticed that I snore loudly or that I stop breathing in sleep? Do I move around a lot in sleep or kick my legs? And do I act out my dreams? It's also very important not only to focus on the nighttime symptoms, but also the daytime sleep symptoms. I have to ask myself, do I feel fatigue and fall asleep during the day when I don't need to, or at least I need to stay awake, like driving or at the red light, for example. So I want you all to start asking these questions to yourself and your caretakers or your sleep partners. In addition to that, there are also other possible symptoms that we should look at. As we talked about the loud or frequent snoring, some pauses in the breathing. If you are making choking or gasping sounds during sleep, if you feel very fatigued and tired during the daytime, when you wake up in the morning, you don't feel refreshed. You have headaches on waking up in the morning, you sweat a lot during sleep, you wake up with dry mouth. If there is frequent urination and nocturia, which causes the sleep disruption, if there are any acid reflux symptoms, if there's a lot of tossing and turning in sleep, and also the memory problems and a brain fog or a poor concentration, as well as some mental health issues like anxiety and depression, which we can trace back to poor sleep also. Coming back to myasthenia and sleep. So I did this talk a few years ago, and since then I was looking at the literature, and we really don't have a lot of data regarding sleep, importance of sleep and sleep disorders in myasthenia gravis. And I was just talking to Dova about it, that maybe we should consider doing a research study to really focus on the sleep issues in patients with myasthenia gravis through MGFA. Because we just don't know, we just don't know how common the sleep disorders are in myasthenia. There are no clear guidelines on how to treat different sleep disorders in myasthenia. And a lot of our myasthenia patients feel fatigue or feel tired. So it is difficult to know whether that fatigue is coming from myasthenia or that is coming from really untreated sleep disorders. We also don't know what kind of sleep disorders occur in myasthenia. Is it just sleep apnea, hypopnea syndrome, or there are patients who also have insomnia or restless leg? And there are some studies, and we'll talk about it. But not a lot of literature, and I think there is a lot of lacuna about that. We also need to know that how medications that we use in myasthenia, we use all kind of medications, and how do they affect or disturb sleep. And we know steroids. We know that how steroids have significant effect on sleep because it can cause anxiety, it can cause restlessness, it can cause insomnia. And not only that, we use very different kind of dosing of steroids, and all different kind of dosing have different impact. But even low dose steroids can affect the sleep significantly. It can also cause weight gain, and it can cause obesity, and in that leads to the fat deposition around our oral airways, and that leads to the sleep apnea as well. So steroid has significant impact on sleep, and we definitely need to learn more about that. So what are typically common symptoms in sleep symptoms? One is that patients feel that they just cannot sleep. Some patients feel that they feel too sleepy during the daytime, or that they have excessive movements in sleep. And with just these three different the scenarios we can look into, and we can see that patients who feel that they cannot sleep, the typical sleep disorders associated with that is insomnia, but also sleep apnea, restless leg, and periodic limb movement, because that does cause disturbance and the patient just cannot sleep. The patients also feel too sleepy during the daytime, especially, and that occurs in patients who have untreated sleep apnea, who have periodic limb movements, which disturbs their sleep, or patients who have narcolepsy. And then there are symptoms of excessive movement in sleep, which is typically associated with this periodic limb movement, but also what we call as parasomnias, and that is sleepwalking, sleep talking, acting out of dreams. Again, we just don't know if there is any correlation in patients with myasthenia specifically. So let's talk a little about different sleep disorders a little bit. So let's start with sleep apnea, hypopnea syndrome, or what we call as obstructive sleep apnea. This is the most common sleep disorder, period, but it's also most common sleep disorder in patients with myasthenia gravis. And there are reasons why that is the case. One is neuromuscular weakness. There is a weakness of our chest wall. There is a weakness of our muscles in the oropharynx area. And that leads to the collapse of the tongue and narrowing of the airways. And that leads to the, obstruction of the air going into our lungs. But in addition to this neuromuscular weakness, we just talked about how the obesity, elevated BMI affects us because there is also medication effect, for example, steroids causing weight gain, etc. So it's kind of a combination of that, and that really creates a perfect storm, especially in patients with myasthenia to develop sleep apnea. There are some anatomical features across the population that predisposes patients to sleep apnea. One is a neck size. So in men, if you have more than a 17-inch collar, or women more than 16-inch, we see that that's very common in those patients to have sleep apnea. Also, when we look at their airways, if they have a narrow airway, you have very large tonsils and adenoids, if there's a large tongue and a recessed jaw, all that can lead to narrowing of the airways and predispose to sleep apnea. So what are the indications of sleep apnea and myasthenia? If you see your, in addition to age and increased BMI, and as we talked about the diaphragmatic and restrictive lung weakness and neuromuscular weakness, when you see your doctor and they do the pulmonary function test, the breathing test, if they're abnormal, that increases the chance that one would have sleep apnea. Or if they do the overnight pulse ox, and if it is less than 90% saturation, that also increases the chance to predict that there would be possibility of sleep apnea. But many patients with myasthenia have bulbar weakness. We have trouble swallowing and shortness of breath associated with that, or speech disturbance, and all that occurs because of significant weakness in the oropharyngeal muscles, and that leads to, of course, sleep apnea. So as you can see here in the cartoon here, that the air is trying to pass from these from the airways, and if the airway is open, the air comes from the nose and goes. This is the tongue, and comes posteriorly, and it can go into the lungs because of the airway is open. However, as you can see here, that although you can breathe through your nose, but if the airway, the tongue falls backwards, and the airway is narrow, the airway gets blocked, and you have air not going through your lungs. And that causes a lot of episodes of what we call as a sleep apnea or hypopnea. And that causes sleep fragmentation because you wake up frequently because you're not getting enough oxygen. And this can occur a few times a night, or in more severe cases, many times a night. So how do we define apnea? I think it's important for you to understand apnea is that if there is a pause in the breathing for 10 or more than 10 seconds, that's we define as apnea. Hypopnea is that the breathing becomes shallow enough that if we look at the oxygen saturation just before the episode of hypopnea and after, that there is a desaturation, the oxygen level drops by 3 to 4%. And we calculate this apnea and hypopnea when we do the sleep study, and then we divide based on number of sleep hours, and we come up with a number called apnea hypopnea index, which is the episodes per hour. And as you can see here, if there are less than 5 number of these episodes, that's normal. But if there's episodes occur 5 to 15 times an hour, that is a mild sleep apnea. If they occur around 16 to 30 times an hour, then we call it as a moderate sleep apnea. And if they occur more than 30, that is a severe sleep apnea. So there was one study done, as I show you here, there was one study done in patients with myasthenia and sleep apnea, and they looked at the frequency, and they saw that almost 24%, so a quarter of the patient had severe sleep apnea. So what happens when you have this recurrent episodes apnea and hypopnea when you are sleeping that leads to awakening throughout the night? The sleep becomes very fragmented. Sometimes what it also causes is that you may not wake up completely and you may not be aware, but it leads to frequent changes in the sleep stages, what we define that as arousals. And that's also very interrupting to the sleep. People wake up in the morning, they don't feel refreshed, they have fatigue during the daytime, they have frequent urination at night, they have difficulty concentrating, sometimes headaches on waking up in the morning, and then the sleepiness can lead to all kinds of issues during the daytime and falling asleep in inappropriate times. So the risks that are associated with untreated sleep apnea is that we have seen that the myasthenia gravis can become worse if you have underlying untreated sleep apnea because of the oxygen desaturations. And we talked about how that increases the chance to have infections, for example, because your sleep is just not sound. But there are also other issues that can occur. We feel sleepy. That leads to the motor vehicle accidents, for example. There are cardiovascular issues like high blood pressure and heart disease. You can have increased chance to have stroke and mini strokes. If patients who have diabetes, it can become worse because of this frequent desaturations that releases the stress hormone like cortisol, and that leads to increase in the glucose levels and makes the diabetes worse. Headaches, depression, and anxiety, and poor memory. And overall, there is increased mortality in patients who have untreated sleep apnea. There was one study done that showed that 60% of the myasthenia patients who had sleep apnea, they showed that they had major memory issues than patients who did not have sleep apnea. This is specifically in patients with myasthenia. So 60% is a large number. More than half of the patient felt that their memory was affected. So how do we test for sleep apnea? We do the sleep study. This cartoon shows here that you go to the sleep lab and you stay there overnight, and then the patients are hooked up to different sensors, and that helps us to understand what is their brainwave activity, that helps us to see what sleep stage they are in. We looked at the eye movements, that helps us to see if the patient get into REM sleep or rapid eye movement or dream sleep. We also check for the tone of the muscles called EMG. But there is also another way to do the sleep apnea test, and that is called the home sleep apnea test, that you can take your machine, the sleep lab would give you the machine, explain you how to put it on, and then you bring it back the next day. And sometimes it is helpful, although not in all kinds of sleep disorders, especially when we are looking for periodic limb movement, for example, then it's not a very helpful test because we don't measure that at the sleep testing done at home. So how do we treat sleep apnea? The lifestyle changes are very important. Of course, the weight loss or cutting back on alcohol, quit smoking, avoid sleeping on your back. These are the lifestyle changes that you can do to improve the possibility of sleep apnea. But then there are other ways that we can also address it. And one is a dental appliance. So there are some dentists who can make something called mandibular advancement device, which looks like a retainer, which basically pulls the jaw forward and opens the airway. There are surgical options which have become less favorable now, but tonsillectomy is something we consider, especially in children. Then the positive airway pressure therapy or a PEP therapy, we'll talk a little bit more about it. It is one of the best treatment for sleep apnea. And now there are other devices coming up. One is called Inspire, for example, which is something like a stimulator that is placed under the skin and that helps to contract the tongue and then open the airways. But the PEP therapy is the most effective and the fastest way of treating sleep apnea because as soon as you put it on, it starts working. So it's like a pneumatic splint, and that the machine uses a stream of air to keep your airways gently open. And so it eliminates these breathing pauses and snoring. So just putting someone on oxygen without addressing this opening of the airways with the CPAP is not going to help. So I see some of the patients who just are placed on oxygen, but if the airway is narrow and occluded, even if you are on oxygen, it's not going to reach to your lungs. So it's very important that if there is a sleep apnea, then the patients are on this therapy. So then there is a mask, which, as you can see here, this patient is having closed airway, and then you put the mask on, which is attached to a hose, and then the hose is attached to this to the CPAP machine or a BiPAP machine. And these most PAP units then send the air at a particular pressure that is determined by sleep study, for example, and that the air goes in towards the lungs. They also come with something called timed pressure ramp setting. So the airflow starts at a very low level so that you can get used to the lower pressure of the airflow and start falling asleep comfortably. And then it goes up and stabilizes at the pressure that is determined to treat your sleep apnea. So different type of PAP therapies. One is called CPAP, which is a continuous positive airway pressure, mainly for the sleep apnea, not for hypoventilation only. Then there is something called AutoPAP, which sometimes helps to auto-titrate the pressure settings. BiPAP is also used in patients, which is a bi-level pressure settings. So when you breathe in, the pressure is a little bit high. And then when you breathe out, the pressure is a little bit low. So it is easier for you to breathe out against the high pressure because that pressure is a little bit low. So you don't have to breathe out against very high pressure. It is good for nocturnal hypoventilation as well as sometimes patients who do have apnea as well as obstructive apnea as well as central apneas. And there are some more sensitive triggers with ASV or a trilogy. And the trilogy is something we use in patients who are very advanced sleep disorder. There are different kind of masks, as you can see. So no matter what kind of mask it is very important that it fits well and it's comfortable. So because if it is not comfortable, you won't be using it. Sorry. So the mask must make a seal in order to keep your airways open throughout the night. There shouldn't be a lot of air leak because if there is a leak, then it will prevent and maintaining a good pressure constantly. They can vary based on facial features. And as you can see here, this is a different kind of mask. But this is a full face mask. This is, for example, the nasal mask, which just sits in front of the nose. This is something called nasal pillows, which just goes a tiny two apertures that just go and sit under the nostrils. And this is a full face mask. I mean, it is not uncommon for patients to complain that it is uncomfortable, especially in the beginning, and you may have to use desensitization procedures, like you want to try to use it during the daytime when you're sitting or watching TV and gradually get used to it. But the most common is the mask-related or interface-related skin injury due to the pressure. Sometimes the air leaks and causes the eye irritation or unintentional air leaks. Sometimes the patient feels that they are swallowing a lot of air and the gastric distension that occurs, especially patients who need very high pressure. And we can do that, we can manage it by reducing the airway pressure or correcting the asynchrony or use kind of abdominal binders. So coming to the next sleep disorder in myasthenia is insomnia. And insomnia is not uncommon in patients with myasthenia. And there are a lot of risk factors in myasthenia associated with insomnia. One is the severity of myasthenia. Patients who have more severe disease can have insomnia. Patients who are in MG crisis, who are placed on these different medications. Of course, anxiety related to the fluctuating nature of our myasthenia. We know it's a snowflake disease. And so that anxiety also leads to insomnia. The shortness of breath in itself can lead to anxiety. That would make you feel very anxious if you can breathe well, and that leads to insomnia. Medications, we talked about steroids, have a strong impact and causing insomnia. Patients with myasthenia, it's not uncommon to have depression. And of course, patients with increasing age, that also causes insomnia. So there was one study done in myasthenia, which showed that 40% of the patients actually did have insomnia, which is a large number of patients complaining of insomnia in a patient population. Patients also are given different medications to treat insomnia. And there are different medications I have listed here that MGFA will share with you. But some of the medication to keep in mind that, for example, just antihistamines, that have been case reports that they have made the myasthenia worse. Even gabapentin, there have been some case reports that it triggered myasthenia symptoms and made it worse. And most likely that could be because of the sedation and not able to breathe well. Mirtazapine have shown that at least in less than 1% of the patients, there's a medication called Ramiltion, again, because of the respiratory depression. And similarly, medications like benzodiazepines or medications like Ambien type of medications that all could potentially make myasthenia worse. So just keep in mind when your doctors prescribe you these medications. Switching gears to another disorder called restless leg syndrome and in myasthenia. So, we think sometimes, well, it's not common in patients with myasthenia. What could be the correlation? But there was one study which showed that the 43% of the patients with myasthenia did report symptoms of restless leg syndrome. And when they compared it with controls who did not have myasthenia, only 20%. So almost more than double than control patients did have restless leg syndrome. So again, keeping in mind that this is yet another sleep disorder, which is not uncommon in myasthenia. And 40% of those patients, one study showed, had moderate to severe restless leg syndrome, which can have tremendous impact on sleep quality and the quality of life. So what are the 4 cardinal features of restless leg? One is that the patient complained they have uncomfortable sensations that begin while they rest at the end of the day and when they're trying to fall asleep. The sensations feel better when they move. So they try to get up and move around and it makes them feel better. When they sit down again, symptoms start again. The symptoms become worse in the evening and they have this type of leg movement. They kick their legs up during sleep, which is called periodic limb movement. That some of the patients who have restless leg, not all of them have periodic limb movements. And it is very difficult to describe the sensation of restless leg in this. For a lot of patients would come and say they just cannot describe it. It's almost undescribable that what sensations they feel. But there are different ways that they describe. Some patients say it is a creepy, crawly sensation. Sometimes it is itching and burning. Sometimes it is searing pain or tugging or pulling sensations or drawing sensations, like water flowing or something crawling, like bugs crawling, like an electric current sensations. They feel just restless. And some patients just say that the legs feel painful, but then we try to put in the context of other symptoms and see if this suggests that there is a potential of restless leg syndrome. So these are just something I wanted you to be aware of, possibility of different sleep disorders. Let's talk a little bit about the sleep hygiene. So we want to make sure that we have a very consistent sleep schedule. We want to get up at the same time every day, even on weekends or vacations, which is hard, but at least when we are trying to address our sleep, it is important to have a very good sleep schedule. And we need to also set the bedtime that is early enough for you to get 7 to 8 hours of sleep. No point in going to sleep at midnight or 1 a.m. and then you have to wake up at 6 or 7 a.m. for work. So make sure that you have enough time. Don't go to bed unless you are sleepy. Not just fatigued, but sleepy. And if you don't fall asleep after 20 minutes of staying asleep, then get out of the bed. Do some quiet activity without a lot of light exposure. Especially important not to get on electronics at that time. Arise at a regular time every morning, regardless of the sleep time. So even if you haven't slept enough, try to wake up at a more fixed time in the morning, because even if you haven't slept enough, it will create a sleep debt and you probably will sleep better the night after or after that. Avoid lengthy naps, avoid late naps, exercise regularly and maintain a healthy diet. Avoid consuming caffeine in the afternoon or evening because caffeine is very stimulating. Avoid consuming alcohol before bedtime. Alcohol has a tendency to make your sleep apnea worse. It also causes respiratory depression, but also affects the sleep quality. And then reduce the fluid intake before bedtime so that you don't have to wake up frequently to go to bed. So what is a good bedtime routine? As we talked about, establish a relaxing, non-alerting bedtime routine. Make your bedroom quiet and relaxing. Keep the room at a comfortable, cool temperature. Limit exposure to light in the evenings. Turn off all the electronic devices 30 minutes before bedtime. And don't eat a very large meal before bedtime. Avoid alcohol, nicotine, as we talked about. So the bed is only to sleep. So no eating, TV watching, radio listening, planning, or problem solving in bed, because your mind will get then very active and it will be difficult to fall asleep. And exercise as your MG allows, but not too close to the bedtime because it is also stimulating. And then, as we talked about, keeping a very comfortable, dark, quiet sleep room. Technology is another thing because we use a lot of technology and we say that our bedrooms are getting smarter, but we really need to ask ourselves, are they really getting smarter? There are a lot of gadgets and apps. There are wearable trackers, smartwatches, headbands. They claim that they are going to measure brain activity and tell you about your sleep. But again, are they interfering with your sleep? That or not? That's something we have to remember and assess. So we have to ask ourselves, are these gadgets really helping to solve our sleep problems? Because there's not a lot of data regarding the validity. It is getting better, I must say, but not to a degree. And there may be some technology, but having an iPad or a phone till you try to fall asleep and having that exposure of the light is just not good for us to fall asleep. But some technology can help. There are some apps that can track snoring, that can track your sleep schedule when you're traveling and there is a jet lag, it can tell you how to sleep. There are some guided meditation apps that could be helpful or white noise apps. So you want to really see which technology is helpful and is validated. But we have to remember that it is not a quick fix and we have to address the sleep disorders. So I'll end with this slide, which talks about some helpful tips that you can that can help you for you to sleep better, and addressing the structure of the sleep, as we talked about, the scheduling, the light exposure, avoiding in the evening, but more light exposure in the morning hours, avoiding the electronics in the bedroom, proper exercise, but also timing of that, and then prioritizing sleep, because as we discussed in the very beginning of the talk, sleep is an extremely important part of our life, and it's very important for us to rejuvenate, to continue to live a healthy life. So I'm going to end here, and I'll be happy to take any questions if you have.
We do have quite a few questions. So the first question is, my sleep issues are caused by neuropathy in my feet.
Yes.
I never get 7 hours of sleep. Is there anything I can do?
So the neuropathy, of course, it could be painful and it can affect your sleep. Sometimes the medications that people use for neuropathy can also interfere with sleep consistency. There have been some studies which have looked at the correlation of sleep of restless leg syndrome and neuropathy. There's actually one study that we are doing here, looking at the correlation of peripheral neuropathy and restless leg syndrome. So you may want to ask your doctors and see if there is an indication of restless leg syndrome, because there are specific medications that you can use for restless leg syndrome and that can improve your sleep.
Okay, thank you. What sleep medication is good and safe for MG? I am taking Ativan and Remeron, 7.5 currently, but don't like the Ativan. I have trouble falling asleep and staying asleep, often waking up after 1.5 hours.
Yeah, so that is that you remember we talked with, there's a slide that I'm sure you will share. But Ativan is one of the benzodiazepine type of medication, and it does have something called effect on our breathing. It can suppress our breathing. It can cause respiratory suppression. And if you have an underlying sleep apnea and your breathing is suppressed, then it makes it even worse. So you definitely want to talk to your doctor and ask them about maybe doing the sleep study or figuring out if you do have any underlying sleep disorder, and address that first so that you know which medications are the best for you.
Great, thank you. The next question is, I find that assessments conducted by neurologists ask about sleep, but no recommendations are made. What is the best way for patients to bring up the issue, and what recommendations or actions might we expect?
That's a really great question, because not many neurologists are trained in sleep, or that unless the patients would bring up the issue of sleep. It's important and should be brought up, but it may not happen in your each visits. I think if you do have sleep issues, you should talk about it to a neurologist. And if they do not practice sleep medicine, then you should ask if they can refer you to someone who specializes in sleep medicine and talk to their sleep specialist. Sometimes the primary care physician are also very good at addressing sleep disorders. But if there are consistent sleep symptoms, then we have wonderful sleep specialists within neurology, within pulmonary, within psychiatry, within primary care. So you can definitely reach out to them.
Thank you. Can sleep tracking devices help in referrals for diagnosing sleep apnea? Like Fitbit has a sleep tracker that looks at the sleep stages.
So as I talked about these gadgets, now we have to make sure that they are validated. For the sleep apnea itself, yes, there are some apps that can track snoring, or Fitbit can track your sleep. But sleep stages have many parameters. So when we see patients in the sleep lab and we do the sleep study, we measure many different things. We measure their brain activity, or we call EEG. We measure their tone, muscle tone. We measure their breathing. We measure their leg movements. We measure their heart rate. We measure their eye movements. And all those sensors putting together helps us to determine if someone is in what stages of sleep. So I'm not sure how strong the science is behind these different trackers. So I wouldn't focus a lot about the sleep stages, and it tells you whether you are having a deep sleep or not. I think for you to know precisely the sleep study, it could be very important. And the home sleep study can also assess the different stages of sleep, not just that you have to go to the sleep lab. So that is an option as well. But definitely don't rely on just gadgets till we know that there are some validated ones that gives very good information.
Thank you. The next question is, have you heard of INAP, INAP apnea treatment? What do you think of it if you have heard of it?
No, there are a lot of newer things in sleep apnea treatment going on. As I said, the Inspire, for example, which puts a little electrodes under the skin, or there is something called Excite. These are the things which help to contract the tongue so that it opens the airways. Sometimes it also depends, before they consider this type of treatment, is the patient's BMI is appropriate. So sometimes I send the patients to ENT for this type of therapy, and they are not able to do the procedure because the BMI is high. Patients with myasthenia may have something we have to be a little bit careful because of some risks associated with the anesthesia, for example. So all these different devices, I think it's very important that one need to, correlate with underlying myasthenia and what is the, what are the symptoms associated with myasthenia.
Thank you. The next question is, what is the difference between a BiPAP and a CPAP, and which is better for myasthenia gravis?
So there is no specific indication for myasthenia. Some patients with myasthenia gravis do okay with CPAP. The CPAP is a continuous pressure ventilation. So you have, let's say, if I set up a CPAP at 10 centimeter, the air is coming out at 10 centimeter of water pressure. So when I take a breath in, it is 10 centimeter. When I take a breath out, I'm breathing against that 10 centimeter through the mask, right? So it is a consistent pressure, or what we call is a continuous pressure, which is the CPAP. BiPAP is called bilevel. And what it means is that when you take a breath in, the pressure is at a higher level, let's say 12 centimeter. But when you breathe out, that pressure, so inspiratory pressure, when you take a breath in, that is a little higher. When you breathe out, which is the expiratory pressure, is a little bit less. So around there's a 2 to 4 centimeter difference. And so you're breathing in at a high pressure. Some patients require very high pressure to correct their sleep apnea. And so someone who requires a pressure, let's say, of 16 centimeter constantly, it is hard to breathe out if it is continuous. So that is the difference, that those patients may be taking the air when they are breathing in at 16, but then breathing out maybe at 12. And so it is easier to breathe out. So that is the difference. There's nothing specific for myasthenia. Many patients do better on BiPAP, but some patients do okay with CPAP also. So your sleep doctor will decide when they put you on a CPAP or a BiPAP and they do the download. There is a way for us to assess how many hours you're using the machine, how good it is, what is the leakage, what is the mask seal, how many times you still are having issues breathing, how many times you're having apnea or hypopnea, as we discussed, every hour. So all those things are very helpful, and your sleep doctor can decide based on that whether you need to move on to BiPAP from CPAP.
Thank you. Is Benadryl an option for sleep long-term?
So Benadryl is, again, sometimes can be associated with sedation and respiratory depression. So you've got to be careful taking those medications, especially if you do have underlying sleep apnea and it is not addressed. And then patients need to, sometimes they get used to the medication and need to keep increasing the dose, and they may have a more negative impact on breathing.
Okay, this is a hard question. I'm waking up at night to go to the bathroom, but am I waking up at night because I have high CO2 or because I have to use the bathroom? When I wake up, yeah, go ahead.
Without doing a sleep study, it is difficult to know if you do have high CO2. So what does it mean, the high CO2? Because sometimes we retain the carbon dioxide because we are not able to breathe it out. And so there is something called end tidal CO2 that we can measure during the sleep study. So if you are really concerned about it, you can talk to your sleep doctor, and they can do a sleep study with that particular sensor. Now, it is difficult to know whether you are waking up because just you are retaining carbon dioxide or because you need to go to the bathroom. And we see that with oxygen desaturation and frequent apnea and hypopnea, people do tend to wake up frequently and go to the bathroom. And sometimes you wake up and you feel like you want to go to the bathroom, even though you don't have that urgency, or that you are awake and you just might as well go to the bathroom. So it really depends, but we have seen the patients who do have untreated sleep apnea have a significant nocturia. And then we also know that, like prostatic hypertrophy and all that in the age group, that a lot of our patients are, especially in male patients, that is another condition that makes your sleep fragmented because you have to go to the bathroom frequently.
The next question is there a risk to the lungs if the BiPAP pressure is too high?
Not necessarily, but again, it depends on what is the pressure. Yes, we have, we have to monitor that. We have to make sure that there is no air trapping that can occur with sometimes very high pressure. So again, it depends on what is the pressure. It really depends on what is the health of your lungs, if there is associated COPD or not. So again, in those situations, you have to work with your lung doctor or sleep doctor very closely to see is there other options to avoid that type of concerns.
Okay, we have a few more questions. Does Mestinon interfere with sleep? I take the time release pill at night, and it seems like I wake up every night around 3 a.m.
So Mestinon in itself is not associated with insomnia, but I would think that the Mestinon does have side effect in the form of excessive, for example, salivation. And if that happens, and if you are choking, then you could wake up because you're not able to swallow or saliva, for example, or that Mestinon increases the abdominal cramping, diarrhea, things like that, and that may be the reason you could wake up. So no direct effect, but it does have this secondary effect that the patient could experience.
Thank you. Thank you, Dr. Desai. This has been great. And I know people have a lot of very specific questions about their particular cases, which I won't go into all of those. But we are going to post this webinar on our website in a day or two, so you will be able to see the slides if you want to see the medication list or rewatch it. And we do thank you for your time today and wish you all a good afternoon.
Thank you. Thanks for the invitation. And I would encourage everyone to talk about their sleep and sleep issues with their doctors. Thank you.
Thank you very much. Bye-bye.
Bye.